So do you see my screen okay?
Yes, we can.
Great. Thank you very much indeed for the warm welcome to join your meeting. I'm delighted to be here. So I'm going to be talking about combination therapy with T4 and T3, and just talking about some of the current recommendations regarding this treatment. So I have no disclosures that are relevant. And what I'm going to do is very briefly talk about the standard of care treatment for hypothyroidism. Then I'll discuss some of the knowledge gaps that we have regarding therapy for hypothyroidism. And then talk about the evidence for and against combination therapy with T3 containing products. So just starting with some basics of the standard of care treatment for hypothyroidism, and the picture below is a nice before and after picture of someone treated actually for myxedema coma, and the dramatic changes in her appearance when she's euthyroid. So as we all know, levothyroxine is a prohormone, and it's converted into T3, which is the active thyroid hormone in all the tissues in our body. And levothyroxine has evolved as a standard of care treatment for hypothyroidism for a number of reasons. It's clearly efficacious in treating the symptoms of hypothyroidism in most individuals. We have a very long experience of its benefits. It has a favorable side effect profile. We only get side effects if we undertreat or overtreat. It's generally easy to administer with an acceptable intestinal absorption, and importantly has a nice long half-life, which means that it can be given once a day. It's generally low cost, and it does produce stable levels of T3. And when we're adjusting thyroid hormone therapy with levothyroxine, we do have a number of biomarkers, and obviously the commonest one that is used is the TSH level. And this is just data perhaps suggesting that individuals do have a set point for their TSH. So these are 16 individuals without hypothyroidism with repeated measures of their TSH. And you can see that this individual over here on the right lives with a higher TSH of a little bit above 2, compared with some of these individuals in the middle that have TSHs that run around 1 or so. And so when we do titrate levothyroxine, we can titrate based on the serum TSH, and we may aim for a slightly higher value in older patients. Or we may try to achieve a lower TSH in other patients. So we do have that ability to titrate the thyroid hormone. And disappointingly to us as endocrinologists, we're not that good at keeping the TSH in the desired range in our patients. This is data from a few different studies, all of individuals receiving therapy with levothyroxine. And we see that across these studies, about 60% or so of patients are euthyroid, but a good percentage are undertreated or overtreated. So despite the simplicity of the levothyroxine therapy, we're not as good as we would like at keeping patients euthyroid. So let's move on to talking about some of the knowledge gaps that we have regarding therapy for hypothyroidism. And again, we have a before and after picture of a young girl when she's euthyroid on levothyroxine. So one of the knowledge gaps that we have is patient satisfaction or dissatisfaction. And there are obviously a lot of different studies that address this, and this is just one of the classic ones from Sarah Bannon in 2002. And this group looked at 2 different questionnaires to assess quality of life or well-being. And they scored people with scores above 3 as not doing well, and looked at patients with hypothyroidism treated to achieve a normal TSH and control individuals without hypothyroidism. And you see that with both questionnaires, there were more patients that were unhappy or dissatisfied compared with controls. So between 9 and 14% in this study. And it's this type of data that leads people to say about 15% or so of patients don't do well on their levothyroxine. So what might be the causes of this dissatisfaction? Could it be that we haven't got the TSH level just right for that person? Are there problems with specific thyroid hormone preparations and of levothyroxine? And this probably is not the case. Is it that autoimmunity is playing a role and is negatively affecting quality of life? We all know that people with hypothyroidism have other medical conditions. Could these be contributing to patients not doing well? Is there something about just simply having a chronic medical condition that's deleterious to patients? And then obviously the topic that is the focus of much research is that maybe levothyroxine does not capture normal thyroid physiology, that the T3 levels may be too low and free T4 levels may be too high. And there's obviously also focus on polymorphisms that potentially cause impaired conversion of T4 to T3. So this is data just addressing co-existent medical conditions. So this is a group of individuals who are treated with levothyroxine, a group of matched controls, and it's just looking at the difference in terms of the BMI of the patients and controls, the use of beta blockers, statins, and antidepressants. And you can see that in each case, there is more use of these medications in individuals who are levothyroxine treated. So could this be part of why patients don't feel well? And this is a list from a British publication, just listing a number of different things that could cause symptoms in patients that are euthyroid on their levothyroxine. So a number of medical conditions, nutritional conditions, lifestyle factors. So a whole long list of things that could potentially be confounding our ability to render patients feeling well. This is an interesting study that looked at whether patients knew about their diagnosis of hypothyroidism. So here we have some individuals who did not know that they were hypothyroid at any time. They were asked to report their health, so given a self-report, and 83% felt well. And if you compare this to another group of individuals who did know about the hypothyroidism, these individuals reported a much poorer self-report of their health. So could there be something just about being labeled as having a chronic condition that affects how people are feeling? So just to emphasize that when we focus on quality of life in individuals with hypothyroidism, we're not just assessing the effects of their treatment, but we're looking at many other factors that could be potentially contributing to how they're feeling, and some of these are listed here. So just illustrating that it really is complex. So moving on to what is the biochemical difference in levothyroxine-treated patients compared with the euthyroid state. So this is a study of individuals who were euthyroid, who then underwent thyroidectomy for a number of different reasons, were treated with levothyroxine. And you can see that they were treated to achieve the same TSH, but when you look at their T4, you'll see that their free T4 levels are much higher when they're on the levothyroxine, and the ratio of free T4 to T3 is also higher. And over here on the figure, we see a graphical depiction of the increase in free T4 when these patients are euthyroid on levothyroxine. So could this high free T4 be something that's significant? There are also a number of studies that look at patients receiving levothyroxine compared with the native euthyroid state. And this is data from one of the studies showing the T3 levels in these individuals. And in the gray area, you see the individuals that have normal free T3 levels when taking levothyroxine. So most patients do have normal free T3 levels, but there are 15% that actually have, frankly, low T3 levels. So again, could this be part of the background or underpinning for why people don't feel well? So now moving on to just talk about the evidence for and against combination therapy with T3 containing products. And again, we have another before and after picture. This lady is treated to a euthyroid condition on the right. So there are at least 14 combination therapy trials using synthetic combination therapy, starting with the Beneficious study in 1999 up to about 2016. And these studies are very heterogeneous, meaning that they're different in design. They have different causes of hypothyroidism. They use different dosing regimens, different outcome measures, and the duration of the studies is also very different. And then there are a number of other design problems with some of the studies. So one way to look at these studies is what was achieved in terms of the biochemical parameters in the combination therapy arm. So this is a list of the studies, and this is looking at the TSH in the combination therapy arm compared with the monotherapy arm. And you can see that the TSH levels were not the same in all the studies, and obviously ideally we'd like them to be the same. Free T4 was logically lower in the combination therapy arm. But when we look at T3, we would expect it to be higher in the combination therapy arm, but in some of the studies, it was actually the same. So again, accounting for some of the heterogeneity of these studies. So of these studies, there were 13 trials that looked at health-related quality of life or mood. And the combination therapy study was superior on multiple measures in 2 of these trials. There was superiority of combination therapy on just a few of the measures in the trials, in 2 of the trials. And then the remaining trials showed no superiority. So that was quality of life or mood. If we now look at neurocognitive functioning, and this was studied in 10 trials, and we have a similar result in that one trial showed superiority on many, many measures. One trial showed superiority on just a few of the measures. And then 8 of the 10 did not show superiority. So one potential reason that these studies may not have shown any benefit is it does seem many of them were underpowered. So here we have a list of some of the crossover studies and the number of patients in them, some of the parallel studies and the number of patients in them. And here is a calculation of the number of patients that would be required if there was a large effect size, the number required if it was a smaller effect size, and then the number required if there was only a partial response to the combination therapy. And you can see that only one study, the Walsh study, was actually adequately powered for two of these scenarios. And of the parallel studies, only the Saravanan study was adequately powered. So again, we may be dealing, at least in part, with underpowered studies. Another thing that the studies looked at was treatment preference. So this was studied in 5 crossover trials and 2 parallel design. For the crossover, combination therapy was preferred in 4 trials, and there were 128 patients in those 4 trials. There was no preference in another trial of 101 patients, so actually sort of similar numbers. For the parallel design, one trial, the patients did prefer the combination therapy. That was 130 patients. But the largest trial that we had, the Saravanan trial, there was no preference, and this was almost 600 patients. And then since these studies, there's also been a meta-analysis performed that suggested that there was a 50% chance of preferring combination therapy to T4 alone, but the T3 dose had a significant effect on preference, meaning that the higher the T3 dose, the more likely the patient was to prefer the combination therapy. We have one trial of thyroid extract. There was an abstract reported at the Endocrine Society from the same group, so I think they'll be publishing another study very shortly. But this was their original study where they randomized patients to levothyroxine or desiccated thyroid extract and then crossed them over to the other therapy. And each therapy was 16 weeks. And they looked at multiple different parameters of quality of life and did not show any significant improvement with the desiccated thyroid extract. There was a very modest weight loss, and then there was a preference for the extract that was associated with the weight loss. So this is the data about the weight loss. You see here it is really very modest with the extract. And then this is the preference data with about 50% preferring the extract, and this was significant. So with us not being able to clearly show that combination therapy is more advantageous to patients, we're obviously concerned about the risks of combination therapy. And this would primarily be T3 thyrotoxicosis, particularly with larger doses of T3 or with the desiccated thyroid extract where there's a fixed proportion of the T3. And we're worried about cardiac arrhythmias, decreased bone density. And we don't really know about the degree of risk because we don't really have long-term studies. The longest study we have was the Saravanan study that was a year, but all the other studies were much shorter in duration. And we haven't really looked at the elderly or those with comorbidities, as most of these studies looked at middle-aged women who were fairly healthy. Obviously, we want, for multiple reasons, we want to avoid T3 in pregnant individuals, and there are some studies in the pediatric group, but not as many as in the adults. Looking more at potential risks of T3, this is data from an observational study of liothyronine users compared with those who used only levothyroxine. And in this study, there was no increase in atrial fibrillation or fractures. There was a tendency for increase in antidepressant use in breast cancer and increased use of antipsychotic medications. And this is showing the data about the antipsychotic medications. This is the hazard ratio for using an antipsychotic medication. And this is the proportion of T3 prescriptions. So you can see quite an increased risk with use of the T3 prescriptions. The data about breast cancer didn't hold out in another observational study where they found no association between a number of cancers and liothyronine use. So the T3 levels that we're talking about in these combination therapy trials are very different from the endogenous T3 levels in patients. So this is people with endogenous thyroid function, and you see this, slight change in the T3 levels over the course of the day. This is a very small excursion, and this is the T4 and TSH levels. This is in comparison with what happens when you give a daily dose of T3. So this is 0 time point, and then the T3 is administered. There's quite an abrupt increase in free T3. And then we're showing here the percentage change in the T3 levels following the administration of a single dose of T3. So quite a high peak with the T3 administration, so different from the native state. The other risk of the combination therapy is undertreating and overtreating. This is the data for subclinical hypothyroidism in individuals treated with levothyroxine. So this is the number that we overtreat, shown here. And unfortunately, when we use combination therapy, it seems like we overtreat even more individuals. Again, perhaps speaking to how hard it is to use combination therapy. So what about a sustained release T3? So this is a product that has been tested in Italy, T3 sulfate, and this is the T3 levels following an administration of T3 sulfate, and you can see fairly steady levels of T3. This is a polyzinc T3 that has been tested in hypothyroid rats, is entering clinical trials in humans as we speak. And the way that this is supposed to be sustained release is the polymer is retained at the brush border in the intestine and absorbed more slowly, resulting in sustained T3 levels. So hopefully we'll hear more about these products and other products in the future. And we do know from the studies that we already have that once daily T3 gives you peaks and troughs, twice daily gives you peaks and troughs, even 3 times daily, unfortunately, gives you some peaks and troughs shown in the red. So perhaps what we do need is a truly sustained release T3 that has nice even levels of T3 as shown in the green. So given all these caveats about the use of combination therapy, why do physicians prescribe combination therapy? So obviously we have data about polymorphisms in both thyroid hormone transporters and the deiodinases. And the classic study from Panica that looked at the threonine 92-alanine polymorphism showed, this was a retrospective study of individuals from the Watt study, and they showed that this genotype was associated with worse scores on the general health questionnaire while the patients were taking the monotherapy, and also a better response to combination therapy than the other genotypes. There were some problems with the power of this study, so this is not, definitive and does need to be repeated prospectively. And not all data support this polymorphism data. This is another study that looked again at the threonine 92-alanine polymorphism, a number of different parameters in the wild type, the heterozygote and the homozygote, and this is just on levothyroxine therapy, but there was no difference in, according to genotype in this study. So another reason that people may prescribe T3 is because patients have low T3 levels. And so this is a study that looked at a small number of patients who were prescribed T3 and either responded, meaning they wanted to continue the therapy, or they did not respond, meaning they did not want to continue the therapy. And so what you see is that the responders had the same T3 levels as the non-responders, both at baseline and during therapy. And there was no difference in any of these parameters according to T3 parameters according to responding or not responding. Another reason that people may prescribe combination therapy is for the hope that it will improve quality of life in patients. And this is an open label study in which 23 patients with persistent symptoms were all switched from monotherapy to combination therapy. And a questionnaire was conducted at baseline 3 months and 12 months. And quality of life improved. And here we're looking at the improvement in tiredness as patients were switched to the combination therapy. So this probably influences the prescribing patterns of our physicians. Another thing that may affect us is if a patient asks for T3. So this is a patient who has multiple symptoms and is requesting combination therapy. Here you see her biochemical parameters. So she's perfectly euthyroid. And this question was given as a survey to members of the American Thyroid Association, and they were asked how would they respond to this patient's request for T3. Would they continue levothyroxine, or would they in fact add T3? And in this survey, the most common response of physicians was that they would actually prescribe T3. So almost 34% said that they would prescribe T3 for this patient, presumably affected by that patient's request. So what about the future in terms of combination therapy trials and clinical use? So we talked about how the studies that have been conducted thus far have flaws and are underpowered. These are some results from a consensus statement in which the individuals involved did think that there was enough evidence that we should conduct additional trials. And they felt that in future trials, it would be very, very important to use a thyroid-related quality of life questionnaire in order to look at baseline satisfaction. And that the patients should be fairly dependent on levothyroxine. So they should require at least 1.2 micrograms per kilogram per day. They also felt that most individuals felt that patients should be excluded for other causes of their symptoms. In terms of what should be the primary outcome in any future trials, there was agreement that a patient-reported outcome should be used and that the study should be adequately powered for this outcome. And one questionnaire, the ThyroTxiii, was favored. And it was also felt that it was very important to formally assess patient preference in this trial. In terms of trial design, clearly everyone agreed that a combination therapy trial should be randomized, placebo-controlled, and blinded, and that a parallel design trial was favored. Most people, most of the physicians involved did think the trial should be longer in duration, so at least 6 months. Some people felt that a year was too long and there would be dropout from the study, so we didn't get 100% agreement on the year in duration. So meanwhile, while we're waiting for these trials to be conducted, and there are some ongoing in Europe and Australia, what patients might we consider for combination therapy at the current time? So definitely it should be individuals that have persistent symptoms despite an adequate dose of levothyroxine, and we should have excluded comorbidities that could be contributing to the symptoms. Also, it may be important that patients should have reliance on their levothyroxine, meaning that they would require at least 1.2 micrograms per kilogram. And obviously, we don't want to put patients with comorbidities such as, say, osteoporosis at risk. And then there's clear data that we should not be using combination therapy in pregnant patients. A starting dose of T3 should be a physiologic one. So for example, 5 micrograms for those taking 100 micrograms of levothyroxine. This might entail cutting tablets, and also twice daily dosing was felt to be important. and then reducing the levothyroxine dose to accommodate the addition of the T3. 3 times daily dosing, I think, would be ideal from the parameter of the steady state that you're trying to achieve, but obviously is very, very hard for patients to adhere to. We'd be looking at patient self-reported improvement, not wanting to suppress the TSH, looking for signs of T3 thyrotoxicosis. I don't think we're so concerned about cancer progression risks. And then obviously we want patients to be adhering to the treatment so we can really test whether it's working, and we should discontinue the treatment if there does not seem to be a benefit. And so I think it's very important that if we are testing combination therapy, that we're doing it in a positive way that will help the health of our patients as depicted on this right-hand side picture, as opposed to kind of falling down a slippery slope and ending up with harms to our patients from T3 thyrotoxicosis. So thank you very much for your attention, and I'm going to stop here.
Thank you, professors, for this informative presentation. And I see in the question and the answers no questions.